Obesity and diabetes. Initial talking points. Weakness of data. Self-report. Exercise and T2DM risk. Improved control of risk factors. Health at current weight. Health benefit. Reduced mortality risk. Diabetes mellitus definition. A group of diseases characterized by high blood glucose concentrations resulting from defects in insulin secretion, insulin action, or both. Obesity and diabetes prevalence by age. Percent. Sullivan P.W. et al. Obesity, inactivity, and the prevalence of diabetes, and diabetes-related cardiovascular comorbidities in the U.S., 2000 to 2002. Diabetes Care 28, 1599 to 1603, 2005. Obesity and diabetes prevalence by race. Sullivan P.W. et al. Obesity, inactivity, and the prevalence of diabetes, and diabetes-related cardiovascular comorbidities in the U.S., 2000 to 2002. Diabetes Care 28, 1599 to 1603, 2005. Obesity and diabetes prevalence by education. Sullivan P.W. et al. Obesity, inactivity, and the prevalence of diabetes, and diabetes-related cardiovascular comorbidities in the U.S., 2000 to 2002. Diabetes Care 28, 1599 to 1603, 2005. Obesity and diabetes by activity. Sullivan P.W. et al. Obesity, inactivity, and the prevalence of diabetes, and diabetes-related cardiovascular comorbidities in the U.S., 2000 to 2002. Diabetes Care 28, 1599 to 1603, 2005. Obesity trends. Diabetes trends 1990, 2001, 1990, 2001. These maps show the dramatic increase in obesity and diabetes in the United States from 1990 to 2001. This increase is important because obesity is a major risk factor for type 2 diabetes and because about 55% of adults in the US who have diabetes are also obese. CDC. Reference. BRFSS, CDC 1990 to 2001. Centers for Disease Control and Prevention. Prevalence of overweight and obesity among adults with diagnosed diabetes. United States, 1988 to 1994 and 1999 to 2002. MMWR. 2004 53, 1066 to 1068. BRFSS, 1990 2001. A crisis in the making. Millions of Americans diagnosed with diabetes. A crisis in the making. 20 million American adults of impaired glucose tolerance, IGT. 13 to 14 million Americans of impaired fasting glucose, IFG. 40 to 50 million Americans of metabolic syndrome. In 2002, diabetes-related costs in the U.S. were $132 billion. Average annual cost for medical care for people with diabetes is $13,243 versus $2,560 for persons without diabetes. American Diabetes Association Standards of Care. www.diabetes.org accessed the 13th of February 2008. American Diabetes Association Standards of Care. www.diabetes.org, accessed the 13th of February 2008. Diabetes and prediabetes types. Type 1, formerly IDDM, Type I. Type 2, formerly NIDM, Type 2. Gestational diabetes mellitus, GDM. Prediabetes, impaired glucose homeostasis. Other specific types. Diabetes type 1 represents about 5 to 10% of all cases of diabetes. 2 forms. Immune-mediated, beta cells destroyed by autoimmune process. Idiopathic, cause of beta cell function loss unknown. Diabetes Care, 30, S1, January 2007, type 1 diabetes. Diabetes type 1 symptoms: hyperglycemia, excessive thirst, polydipsia, frequent urination, polyuria, significant weight loss, electrolyte disturbance, ketoacidosis. Type 1 diabetes causes immune-mediated idiopathic, cause unknown. Genetic predisposition. Autoimmune reaction may be triggered by viral infection, toxins. Destroys beta cells in pancreas that produce insulin. Idiopathic, cause unknown. Strongly inherited. African or Asian ancestry. Diabetes Care, 30:S1, January 2007. Type 1 diabetes pathophysiology. At onset, affected persons are usually lean, have abrupt onset of symptoms before age 30. Honeymoon phase, after diagnosis and correction of hyperglycemia and metabolic derangements, need for exogenous insulin may drop dramatically for up to a year. 8 to 10 years after onset, beta cell loss is complete. Diabetes type 2. Most common form of diabetes, accounting for 90% to 95% of diagnosed cases. Combination of insulin resistance and beta cell failure, insulin deficiency. Progressive disease. Ketoacidosis rare, usually arises in illness. Diabetes type 2. Diabetes type 2 symptoms. Insidious onset. Often goes undiagnosed for years. Hyperglycemia. Excessive thirst, polydipsia. Frequent urination, polyuria. Polyphagia. Weight loss. Diabetes type 2 risk factors. Family history of diabetes. Older age. Obesity, particularly intra-abdominal obesity. Physical inactivity. Prior history of gestational diabetes. Impaired glucose homeostasis. Race or ethnicity. Diabetes type 2 pathophysiology. Results from a combination of insulin resistance and beta cell failure. Insulin resistance, decreased tissue sensitivity or responsiveness to insulin. Endogenous insulin levels may be normal, depressed, or elevated, but inadequate to overcome insulin resistance. Diabetes type 2 pathophysiology. Insulin resistance. Compensatory insulin secretion, glucose remains normal. As insulin production fails, postprandial blood glucose. Liver production of glucose increases, resulting in fasting blood glucose. Glucotoxicity and lipotoxicity further impair insulin sensitivity and insulin secretion. Gestational diabetes mellitus, GDM. Glucose intolerance with onset or first recognition during pregnancy. Occurs in 7% of all pregnancies, 200,000 cases annually. Does not include women who have diabetes diagnosed before pregnancy. Usually diagnosed during the second or third trimester of pregnancy when hormonal changes cause insulin resistance. May or may not require insulin treatment. Diabetes Care 30, Supplement 1, January 2007, Prediabetes, Impaired glucose homeostasis. Impaired fasting glucose, IFG. Fasting plasma glucose, FPG, above normal, greater than 100 mg/dl and less than 126 mg/dl. Impaired glucose tolerance, IGT. Plasma glucose elevated after 75 grams glucose load, greater than 140 and less than 200 mg/dl. Diagnosis and classification of diabetes mellitus, Diabetes Care 2007 S4246. Metabolic syndrome characteristics: insulin resistance, compensatory hyperinsulinemia, abdominal obesity, dyslipidemia, elevated TGE, low HDL, hypertension, risk factor for cardiovascular disease and glucose intolerance. Methods of diagnosis: fasting plasma glucose, FPG, casual plasma glucose, any time of day, oral glucose tolerance test, OGTT, not generally recommended for clinical use. Revised diagnostic criteria. Standards of medical care in diabetes 2007. Diabetes Care 30:S4S41, 2007. Screening for DM all persons greater than 45 years, repeat every 3 years. Higher-risk persons, screen at younger age and more frequently. Overweight, BMI greater than 25. First-degree relative with diabetes. Higher-risk ethnic population. Delivered baby greater than 9 pounds or diagnosed GDM. Hypertensive. HDL less than 35 mg/dl or TG greater than 200. Prediabetes. Polycystic ovary syndrome. Diabetes, treatment goals. FPG 90, 130 mg/dl. A1C less than 7%. Peak ppg less than 180 mg/dl. Blood pressure less than 138th of a millimeter of mercury. LDL-C less than 100 mg/dl. Triglycerides less than 150 mg/dl. HDL-C greater than 40 mg/dl. For women, HDL-C goal may be increased by 10 mg/dl. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Diabetes Control and Complications Trial, DCCT. Subjects, 1,400 young adults, 13 to 39 years, with type 1 diabetes. Compared intensive BG control with conventional Texas. Results: intensively treated patients had a 50 to 75% reduction in progression to retinopathy, nephropathy, neuropathy after 8 to 9 years. Clear link between glycemic control and complications in type 1 diabetes. Diabetes Control and Complications Trial Research Group. The effect of intensive treatment of diabetes on the development and progression of long-term complications in insulin-dependent diabetes mellitus. N. Engel JMAD 339:977, 1993. United Kingdom Prospective Diabetes Study, UKPS. Subjects, 5,102 newly diagnosed type 2 diabetic patients. Compared traditional care, primarily nutrition therapy, with A1C of 7.9% with intensively treated group, A1C of 7%. Intensively treated group microvascular complications by 25% and macrovascular disease by 16%. United Kingdom Prospective Diabetes Study Group. Intensive blood glucose control with sulfonylureas or insulin compared with conventional treatments and risk of complications in type 2 diabetes. UKPS 34, Lancet 352-854, 1998, A. United Kingdom Prospective Diabetes Study, UKPS. Combination therapy, insulin or metformin with sulfonylureas, was needed in both groups to meet glycemic goals with loss of glycemic control over the 10-year trial. Confirmed progressive nature of the disease. As the disease progresses, MNT alone is generally not enough, should not be considered a failure of diet. United Kingdom Prospective Diabetes Study, UKPDS. Prior to randomization into intensive or conventional treatment, subjects received individualized intensive nutrition therapy for 3 months. Mean A1C decreased by 1.9%, -9% to -7%, and patients lost an average of 3.5 kilograms. United Kingdom Prospective Diabetes Study Group, UK Prospective Diabetes, Study 7, Response of fasting plasma glucose to diet therapy in newly presenting type 2 diabetic patients. Metabolism 39 to 905, 1990. Diabetes management. Evaluation of glycemic control, SMBG. SMBG should be carried out 3+ times daily for those using multiple insulin injections, A. For peds using less frequent insulin injections or oral agents or MNT alone, SMBG is useful in achieving glycemic goals, E. Instruct the PT in SMBG and routinely evaluate the PT's ability to use data to adjust therapy, E. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Evaluation of glycemic control, A1C. Perform the A1C test at least 2 times a year in peds who are meeting treatment goals and have stable glycemic control, E. Perform the A1C test quarterly in peds whose therapy has changed or who are not meeting glycemic goals, E. Use of point-of-care testing for A1C allows for timely decisions on therapy changes when needed, E. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Diabetes Self-Management Education, DSME. People with diabetes should receive DSME according to national standards when their diabetes is diagnosed and as needed thereafter, B. DSME should be provided by healthcare professionals who are qualified to provide it based on their training and continuing education, E. DSME should address psychosocial issues since emotional well-being is strongly associated with positive diabetes outcomes. DSME should be reimbursed by third-party payers. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Required elements of recognized DSME programs. Diabetes disease process. Nutrition. Physical activity. Medications. Monitoring, using results. Acute complications. Chronic complications. Goal setting and problem solving. Psychosocial adjustment. Preconception care, pregnancy, and GDM, if applicable. Physical activity improves insulin sensitivity in type 2 diabetes. Reduces hepatic glucose output. Reduces cardiovascular risk factors. Controls weight. Improves mental outlook. Physical activity. To improve glycemic control, assist with weight maintenance, and reduce risk of CVD, at least 150 minutes/week of moderate intensity aerobic physical activity, 50 to 70% MHR, and or at least 90 minutes/week of vigorous aerobic exercise, greater than 70% MHR, is recommended. Should be distributed over at least 3 days a week with no more than 2 consecutive days without physical activity. A. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Physical activity. In the absence of contraindications, people with type 2 diabetes should be encouraged to perform resistance exercise 3 times a week, targeting all major muscle groups, progressing to 3 sets of 8 to 10 repetitions at a weight that cannot be lifted more than 8 to 10 times. A. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Effect of exercise on blood glucose. In well-controlled diabetes, lowers blood glucose. In poorly controlled, under-insulinized diabetes, blood glucose and ketones will increase. If BG 250 to 300 mg/dl, postpone exercise until control improves. Activity in presence of specific long-term complications of diabetes. Retinopathy, vigorous aerobic or resistance exercise may trigger hemorrhages or retinal detachment. Peripheral neuropathy, lack of pain sensation increases risk of injury and skin breakdown. Non-weight-bearing exercise may be best. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Activity in diabetes. Autonomic neuropathy may decrease cardiac responsiveness to exercise, risk of postural hypotension, impaired thermoregulation, etc. Persons with diabetes should undergo cardiac evaluation prior to initiation of increased activity program. Hypoglycemia and exercise in insulin users. Common after exercise. Add 15 grams CHO for every 30 to 60 minutes of activity over and above normal routines. Ingest CHO after 40 to 60 minutes of exercise. Drinks containing 6% or less of CHO can replace CHO in fluid. Adjust fast-acting insulin dose 1-2 for strenuous activity lasting greater than 45 to 60 minutes. Adjustment pre-meal rapid-acting insulin for exercise. Percent dose reduction. Level of exercise. 30 minutes of exercise. 60 minutes of exercise. Very light. 25%. 50%. Moderate. 75%. Vigorous. Source, American Dietetic Association Guide to Diabetes, 2005, p. 77. Nutritional considerations. Overweight and obesity are known risk factors for major diseases. Diabetes, heart and vascular disease, stroke, hypertension, high blood pressure, gallbladder disease, osteoarthritis, degeneration of joints. Some cancers, uterine, breast, colorectal, kidney, gallbladder. You are what you eat. Carbohydrates, sugar, protein, fat, vitamins/minerals. Blood sugar glucose serves as a source of energy, ATP. In many cells, requires insulin for entry. Insulin made by cells in pancreas released on demand. As blood glucose goes up, more insulin is released so that glucose can enter cells and tissues. Disease associated with increased glucose in the bloodstream. Diabetes mellitus. Disease associated with increased glucose in the bloodstream. Types of diabetes: type 1, type 2, younger onset. Treatment equals inject insulin. Type 2. Older onset. Obesity. Strong genetic component. Treatment equals oral drugs/exercise. Absence of insulin. Ineffective insulin. U.S. diabetes prevalence. Diabetes prevalence, race/ethnicity. Complications. Complications of diabetes. Short-term. Hypoglycemia, low blood sugar. Hyperglycemia, high blood sugar. Long-term. Kidney failure. Heart myocardial infarction, heart attack. Brain stroke. Eye blindness. Periphery gangrene, amputations. White blood cells impairment/infections. Aortic atherosclerosis. aortic aneurysm, gangrenous extremity, myocardial infarction, heart attack, renal infarction,